All right, let's get started. No introductions, no warm-up. You're in the hot seat for your surgical boards. I'm your examiner. Let's begin.
You're on. A young man, high-speed crash, he's in shock. The ATLS survey is happening, you're pouring in fluids and blood, but he's not responding. He needs the operating room now. What are your priorities? Talk me through your plan. Be systematic. Okay, you've made the incision. The abdomen is just full of blood. While you're trying to figure out where it's all coming from, your anesthesiologist is yelling at you. The patient is crashing, he's getting cold, his blood gases are acidotic, and now he's not clotting. Your whole surgical plan has to change on a dime. What's your next move? What is your priority now?
Right. You've correctly identified the lethal triad. And you have to understand, this is a vicious, deadly cycle. The cold and the acid are making him unable to clot. The inability to clot means he keeps bleeding. And the massive transfusion you're giving him to replace the blood just makes him colder and more acidotic. You have to break this cycle, or your patient will die right here on the table.
The second you recognize that triad, your entire goal shifts. You are no longer trying to perform a perfect, definitive operation. You are now officially doing damage control surgery. And the objectives are brutally simple. Stop the massive bleeding, control any gut spillage, and get this patient out of the OR and to the ICU so he can be physiologically stabilized. That's it.
So, what are your first moves? They have to be fast and purposeful. You need a huge midline incision for exposure. Then you get all that blood and clot out so you can see, and then you systematically jam laparotomy packs into all 4 quadrants of the abdomen. This pressure will slow down most of the bleeding, and crucially, it buys your anesthesia colleagues time to catch up. Okay, you wait a minute. You start systematically taking the packs out. The pack in the left upper quadrant is completely soaked. You pull it out, and you see brisk, ongoing bleeding from a shattered spleen. There's no time to try and save it. What is the one and only correct damage control procedure here?
A splenectomy, that's it. And it has to be done fast. You grab the spleen, you pull it towards the middle, and you quickly divide all its ligamentous attachments. This brings the hilum, the blood supply, right into your view. The single most critical maneuver is getting control of those vessels without accidentally injuring the tail of the pancreas, which is right there.
And this image here shows that key move perfectly. See how you're pulling the spleen from the outside towards the middle of the patient? That single maneuver puts everything on stretch and delivers the entire organ right into your hands, giving you the access you need to get control quickly and safely.
Now, as you're looking around, you see a big, contained, purplish bruise in the space behind the peritoneum around the kidney. What's your move? This is a classic exam question. If that hematoma is stable and not expanding, you leave it completely alone. Opening that space can turn a contained bleed into a catastrophic one. But if it's actively expanding or bleeding, a nephrectomy is the answer, but only after you've made sure he has another working kidney on the other side.
Okay, you've dealt with the spleen, but now you find a much bigger problem, a tear in the superior mesenteric artery. You can't just tie this off. That would kill the entire small bowel. But you don't have time for a complex graft repair in a patient this unstable. So what's your temporizing, life-saving maneuver? A temporary vascular shunt. This is an absolutely core concept in damage control. For these critical vessels that you just can't ligate, you place a simple plastic tube to bridge the gap. It bypasses the injury and gets blood flowing to the organ downstream. It's not pretty, but it works.
And this is exactly what it looks like. It's as simple as it gets. A piece of tubing, basically an IV catheter or chest tube, stuck in either end of the artery and secured with simple silk ties. This isn't the final repair, not by a long shot, but it reestablishes blood flow, it saves the bowel, and it lets you get on with the operation.
This right here is a high-yield table. You just have to memorize this. You have to know, cold, which vessels you can get away with ligating and which ones you absolutely have to repair or shunt. Tying off the internal iliac is usually fine. Tying off the SMA is a catastrophe. Knowing this list is not optional.
So, what if you find a hole in the bowel? Your number one goal is not a beautiful hand-sewn connection. Your goal is controlling contamination. If it's a small, clean-cut, and healthy-looking bowel, fine, you can throw a few stitches in it. But if it's a destructive, messy injury, you just use a stapler to cut across the bowel on either side of the injury and leave the two ends stapled shut. The reconnection happens another day.
All right, you've stopped the major bleeding, you've controlled the contamination, it's time to get out. But you cannot close the fascia. With all the fluid this patient has received, the bowels are swollen.
Forcing the abdomen closed would cause abdominal compartment syndrome, which is fatal. So you have to perform a temporary abdominal closure.
Good. The patient is packed, temporarily closed, and stabilized in the ICU. In 24 to 48 hours, you're going back to the operating room for the second look. The mindset for that next operation is captured perfectly in this quote. That first surgery was organized chaos. You have to assume you missed something.
The second operation is the complete opposite of the first one. It's calm, slow, and systematic. You gently take out all the packs. You perform a meticulous, top-to-bottom exploration of the entire abdomen. You get an X-ray to make sure no sponges were left behind, and only then, when you're sure everything is okay, do you proceed with the definitive repairs, replacing that shunt with a proper graft, connecting the bowel back together, and finally closing the fascia.
You're not done yet. You have to be able to discuss the complications of the splenectomy you performed. What are the risks? Bleeding, of course, injuring the pancreas or stomach during the procedure, an abscess under the diaphragm, and critically, you have to know about the long-term risk of overwhelming post-splenectomy infection. Knowing the complications is just as important as knowing the operation.
And that concludes this Viva. The real core of damage control surgery comes down to surgical judgment. It's about knowing exactly when to prioritize raw speed over elegant precision. It's knowing which corners you can cut to save a life, and which ones you absolutely cannot. And that is the judgment you must be able to demonstrate. Well done.